Hey everyone, welcome to the Front Row with Ed. If this is your first video, I just want to welcome you to the channel. If you're a repeat offender, welcome back. Today we're going to talk about lateral ankle pain. Now, a couple of distinctions I want to make. If you are having more lateral foot pain versus the ankle, a big culprit is the cuboid. So I've already posted a video on my channel. If you go to the Front Row with Ed, and you'll see it up there. And it's how to mobilize the cuboid. Sometimes we can have fibula, which is what this is, fibular and cuboid pain at the same time. This video is going to talk a little bit more about how to deal with the distal, or the lower part of the fibula. This is the proximal, this is the distal. The fibula kind of acts like a shock absorber. Now what happens a lot of times is after an ankle inversion sprain. So remember, 80% of ankle sprains are inversions, where the sole of the foot turns in, creating a separation on the lateral part of the ankle. The ligament most commonly affected is called the anterior talofibular ligament. And that ligament goes from the talus to the fibula. And there's a nice little notch right there. So if you've ever had a lateral ankle sprain, you can come right off the fibula, dig into that notch a little bit, and it's usually pretty tender. I've been a physical therapist for 25 years now, and so what you'll start to see is common dysfunction in joints. You'll have a joint that'll be stuck in a certain way. The cuboid, for example, tends to get stuck in a downward position, so you kind of mobilize it kind of up and out, just to keep it in simple terms. What happens with the fibula, because remember, the ligamentous stability between the fibula and the talus is so strong that you get a relative anterior displacement of this fibula. So it's not going to be anything that you'll notice on x-ray, but the fibula will actually be kind of shifted anteriorly a little bit. And what that does is it prevents the ankle from going into full dorsiflexion. What happens is when I go into full dorsiflexion, you can kind of see it a little bit in this model, this fibula has to drop posteriorly. And oftentimes it's kind of jammed up. So you lose dorsiflexion of the ankle. Now imagine if I'm a runner, jumper, play basketball, and I repeatedly demand that dorsiflexion out of my ankle, but I can't get it. I'll start to end up getting pain through here. There's two main muscles that we need to be concerned about that traverse along this distal lateral part of the fibula. So let's check out these muscles first.
Now remember, both of these muscles can be sources of pain, especially along the lateral ankle. The first one is the fibularis brevis, and you can see it attaches at the base of that fifth metatarsal. The second one we're after is the fibularis longus, and it's called the longus because you'll notice the tendon actually attaches on the undersurface of the foot.
So I'm going to show you a couple different things. Number one, we have to mobilize this joint. And you can do this mobilization even after a fairly acute ankle sprain, assuming the pain levels are not too high and there's not a lot of external swelling in this area. So what I like to do is I like to put my palm right through there, the muscular part of my thumb right on this distal fibula. But just for the video purposes, I'm just going to use my thumb through here, and I'm literally going to kind of spring that fibula. And what you can do is you can check the other side. That's a real common thing, to kind of get an idea of what this particular person's normal mobility might be. And a lot of times it'll lose that little spring end feel. So this technique requires a fair amount of force into it. So if someone has a fairly acute ankle sprain, they may not tolerate. But if they can tolerate it, you can, even on an acute ankle sprain, start to kind of slowly and gently mobilize that fibula to restore the posterior glide as we go up into dorsiflexion. So this is what it's going to look like. Once again, I'm going to use the beefy part of my thumb, and I'm going to come right through here, and I'm going to put a fair amount of posterior force with my thumb. At the same time, I'm then going to ask my patient here to pull up on their ankle, and I'm going to lean into it this way here and just put some nice pressure. Like I said, you can put a fair amount of pressure. Let pain be the guide for the patient. What we'll do is we'll do sets of 10. As I bring it up to dorsiflexion, I'm putting a firm posterior glide into that fibula. And what you should start to see is a slow increase in the amount of dorsiflexion that the client has. We're looking to do 3 sets of 10 with that. Push down posteriorly on that. After your 3 sets of 10 of mobilization of that distal part of the fibula, you can check to see how the ankle is moving. We should have a little bit better dorsiflexion, and we should have a little bit better spring through that distal part of the fibula. Now, what if you have to perform this mobilization on yourself because you have some distal ankle pain that you feel might be a restriction of the fibula? So if you need to mobilize your fibula yourself, this is going to simulate my right leg, and I'm going to show you the model first. You want to find that fibula, which is the outside bump, which is pretty easy. Then what I'm going to do is, once again, I'm going to put a posterior glide into the fibula. And as I do that, I'm going to rock forward, keeping that posterior pressure as I rock forward. Once again, sets of 10. After a set of 10, I can recheck, see what my ankle feels like, and repeat that for a total of 3 sets of 10. This is what it would look like. Once again, here's the fibula. It's the lateral bump. It's very easy to find. I'm using the beefy part of my thumb. I'm going to come through here. I'm going to put a posterior glide. I can use my other hand here to glide it as well too. And as I keep that posterior glide, I'm going to come forward as far as I can, making sure my heel stays on the table. So this is a closed chain, working on increasing dorsiflexion of the ankle by doing a posterior glide of the fibula. Once again, 3 sets of 10 until that motion is restored. Now you may have to do this repeatedly until you feel like you've got better dorsiflexion of the ankle and a reduction in that lateral amount of pain. I hope that video helped to describe how you may be able to treat lateral or distal part of the fibular pain or lateral ankle pain, especially after activities that require a lot of repeated dorsiflexion. Remember, at the end of this video, I'll put 2 links. The first link is to try to mobilize the cuboid. So if you're having foot pain, that's a little bit more on the lateral aspect. That could be some cuboid issues. You may have a cuboid and fibular issue going on at the same time. Also, I'll put some exercises for TheraBand exercises that after you have restored normal mobility of the cuboid and the fibula, some simple TheraBand exercise that you can do to improve eversion, inversion, and dorsiflexion, plantar flexion of the ankle. All right, if you have any questions, please leave it down below. If you haven't subscribed, please do, and good luck.